Hospital, ZJU University. Dr. Jian-an Wang, can you hear me?
See your
hear you. We
stage.
don't see you.
Yes. Thank you. Welcome you all to join.
Hello, we can see you, and now we can hear you. Hello,
Hi,
Dr. Wang.
hello.
Yes, go ahead, SJ.
Hi, thank you. Thank you all for joining us. Can you hear me?
Yes, we hear you fine. This is David Cohen, and my co-moderator is SJ Park, and we have a great panel here, so we're looking forward to your procedure.
Thank you for joining us, Dr. Wang. It's
Okay.
great. All right.
Okay.
Start there.
Thank you for all of panelists and all of audience. Welcome you to our live demo. So first, let me introduce my colleagues. Dr. Liu, standing next to me, and also Dr. Wang, and all of other colleagues. So now I invite Dr. Liu to introduce the case. Welcome you, Dr. Liu.
Okay, Professor Wang. Okay, good afternoon, everyone. Yeah, today the patient is 71 years old gentleman. The patient has recurrent exertional dyspnea for over 3 years and aggravated for 20 years, and the echo showed severe stenosis, and the patient has a history of uremia. Next one, please. And the New York heart function of this patient is grade 4, and the patient is very small gentleman, and the BMI is about 16.7. And we evaluate the surgical risk. That TS score is over 8%. That's because of the end-stage renal disease and the patient condition. So the open heart surgery was denied by both of the cardiac surgeon and the family members. Next one, please. And this is the echo. You can see the left ejection fraction is quite low, about 38%, and the coronary looks good. No intervention needed. Next one. Yeah, we can see right here the patient is a typical type 0 bicup. And also we can see the calcification in the left coronary side. Yeah, and the area of the valve size is about 565 millimeter square, and the parameter is 87.5. So next one, please. The coronary height is good. Next one. And another problem of this patient is the dilated aortic ascending aorta is about 50.6 millimeter, and the calcification is asymmetric and not so severe. And the projection for this patient is RA06 and a quarter 29. Next one, please. And we can see right here that the access of the femoral artery is good. So, however, the aortic arch is very narrow. You can see right here. Next one, please. Yeah, so for this very high surgical risk patient, yeah, there are so many challenges. type 0 bicuspid, autopsy, and a large annulus with a symmetric calcification and a very narrow aortic arch with horizontal aorta. Yeah, so next one, please. So what's the strategy and the projection for this patient? Yeah, in our center, Professor Wang developed the Hangzhou solution and also included the projection for this patient. So we usually the cuspid inserted by the tricuspid valve is divided into to create a virtual NCC and the RCC for the overlap, just like the tricuspid. And for this patient, yeah, so we just use the caudal and the RAO and the caudal, the same, the cuspid level view with the coplanar view in the same projection in this patient. Next one, please. Yeah, for every patient of the bicuspid in our center, we will use the Hangzhou solution to select the valve size. Yeah, we will use based on the CT scan. So we will choose the proper size of the balloon. If there's a severe waste and with no regurgitation, then we will downsize a choice of the valve. Next one, please. And today we will use, because this very special patient, that then we can discuss which valve type, which valve size, which balloon we should choose for this patient. We can discuss. Next one, please. So today we will use the balloon expandable. This is the domestic, the Chinese-made domestic valve, and the design is quite similar with the Sabin 3. Next one, please. Yeah, for the teaching points. Yeah, for this kind of patient, so which strategy, TAVR or SAVR? Yeah, and also the valve type. So the self-expanding or the balloon expandable valve, and also the valve size. So in our center, we will use the Hangzhou solution. And also for this very special patient, the skill, the technique in very specific complex. So for this patient, we just spend a lot of time for the valve crossing with the wire. Yeah, it's not easy for the manipulation. Okay, that's all for the case presentation, Professor Wang.
Hi, I would like to have your comments on our next step. So just around several discussion points. So what is are you, if the patient is yours, what is your next step? Are you going to do the balloon inflation or you're not going to do? Or if you agree with the balloon inflation before the device implantation, what size, which size of balloon do you prefer for the patient?
So for this patient, we will use the balloon expander for 26.
Okay.
We are,
So first first I would like to the the panelists, for your comments and suggestions. Regularly, do you for this kind of patient? Regularly, do you do the balloon inflation first, or you didn't do balloon inflation?
Anybody want to weigh in on that that comment? About pre-dilating this valve? If not, I will. I mean, I think we've all been taught that bicuspid valves are tricky, and we should generally try to pre-dilate them. And as we saw in the slides, we can not only make it easier to develop and deploy the valve, but we can also learn something about the sizing when we do that. So hopefully that's
okay.
Since you're the one who developed the technique, hopefully that's what you'll be doing. Yeah. So I think the idea of inflating with a balloon is a nice one. But we're not. Well, you got somebody strong put those together, huh?
I think personally, I see we still have a lot of way to sizing. Use like circle method or like the waist method to sizing, because using the Hangzhou solution sizing method, I'm a little bit worried about that, because when you do the balloon dilatation, your valve is not yet prepared. So once you have a acute aortic regurgitation,
so you have to be ready.
Yeah. But because the Hangzhou solution is that it depends on your balloon inflation, contrast injection to choose the size. So properly, that I think.
So you have to have the solution already before you even blow up the balloon, is what you're saying. That I mean, I think it's, I mean, well, we'll see how you do it, but I think, I mean, I'm becoming increasingly convinced that we should predilate, and then, you know, and take a look with the contrast injection to see how the balloon seals. And so I guess I would use a nominal size balloon here.
So, so from
tell us what you're
your
gonna do.
comments, you will do pre-dilatation. So you will do pre-dilatation, but you will select reasonable size, not the size too big, because you are concerned about the regurgitation after dilatation. Is it right?
That's what I'm hearing. That's my feeling. But you know, we don't treat as many bicuspids as you do,
Okay.
so I really do want to see how you do it.
So how
rather
big
than
size
I
the
do it.
balloon?
23.
So we select the balloon size is 23. So we are
23.
so the
Small.
pre-dilatation 23. So the balloon the pre-dilatation has two purposes. First is to to pre-treat the valve. It's easy for implantation of the device. The second purpose is to size the how big we can open the orifice. It's good for will be a good reference for us to select the device size. So the two purposes. So if we use a too small balloon, we cannot provide the we cannot get the information how big size of device we can select. So we just regularly we use one scale less down, one scale right down size with the compared to the annual size, right?
Yeah.
So that's a balloon
Okay.
size. So now we select the 23 balloon. Which type of balloon? I said. So now we
the
go
domestic
through
rate.
the valve. So we put the calcification site in the middle of the balloon.
Mm-hmm.
Then we are going to do a balloon inflation. So 准备起搏吧。
好，
等一下我做 DSA 是吗？
对
所以它撑起来再
等
DSA
会儿他会打的。
啊。
对你准备好了吗？好，
好 ，start pacing
起搏，
起搏。
180。好，不好意思 ，DSA。我再拉回来，
拿回来。
准备打。来，王老师再升起来。哎，好，哎呀，
Stop.
起搏停。
Stop. Sometimes it's very stable. It's very difficult to stabilize the balloon, during inflation. So it means the pacing is not fast enough.
Yeah, maybe 200.
So now the blood
How
pressure
fast
is
were you pacing?
recovering.
16?
So don't worry too much.
Okay.
So we have to pace the pace rate we have to increase the pace rate. Maybe
200准备，
你抽空一点。
抽空了，好，好，好，好，可以稳定了，好，
好
起搏，
Stop
200
pacing, please. 200.
好，王老师可以，DSA，哎，挺好，哎，王老师拉
起
回来一点，好，起，DSA，好，王老师起搏停，好，OK，
It's a little hard to stabilize the balloon, but we still achieved our purpose.
来，王老师，
So we can say that after
来，
we inflate the balloon, the whole balloon, we can say that no regurgitation, but we didn't see the waist of the balloon.
Can you replay that shot so we can all look at it with you?
你再回放一下，Go
回
back，
放，来，
回 back 啊 ，OK，回放。就像他们还是不够，他还是在摆动。
So the waist is
Can I
gone.
see that?
Yeah.
The waist is gone, no regurgitation. So usually for this kind of situation, we didn't do the downsides plan. We just use the regular size of device,
Yeah, 26.
26.
Yes.
So why do you say that?
你是用的不能
balloon.
Yeah.
That's a regular way
what-
for the self-expanding device.
Yeah.
But for this
what would-
case, we
Go ahead.
keep on going, please.
My
Does
question
the-
is, what could you have seen on this balloon inflation that would have made you want to downsize a balloon expandable valve? What might have changed your mind?
So during the inflation of the balloon, if we see the clear waste sign on the balloon without without a contrast back to the left ventricle. So if
So if it was a
the
waste
case
and
with
it
the
was
two
occlusive,
sides,
then okay, then you would downsize. Okay.
waste sign plus without no regurgitation, contrast regurgitation. So we will downsize one scale.
Got it. Okay. So you're going to go back, you're going to use the 26 though, right?
Yes, we are going to use the regular size. But this case, we usually use the self-expanding device for bicuspid. But this case, we had a discussion before the procedure. We think maybe it's better to use the balloon expandable device. The case is very fragile, low weight, but BMI is very low, and also ejection fraction is not good. It's only 38%. Actually, our surgeon declined the surgery on the patient. So
why did you choose the balloon expandable? What made up your mind?
So Dr. Liu, could you give
Yeah,
a
so there's several points. The first one, because the aortic arch is very narrow. Yeah, it's very good for the balloon expandable. Yeah, we can just cross the arch very smoothly. And also because of the aortic the ascending aorta over 50 millimeter. So we want to just one inflation and finish the procedure. And also because of the low LVEF. So if we use the long and the self-expanding, so maybe there's some problem with the crossing the arch. And if we just use the retrieve, yeah, the representative bubble, so maybe it's not good for this patient.
So another reason maybe you know this for this patient, the patient doesn't have the calcification of the annulus. For some patient with the calcification of annulus, we need to concern about using the balloon expandable because the balloon expandable device has the strongest radial force. So we are worried about causing the annular perforation. But the patient does not have the annular calcification, so we don't worry about too much the radial force of the balloon expandable device.
Sounds good. So are
Also
you ready
because
to go?
Yes, we are ready to go. We are.
And are there any meaningful differences between these? Go ahead. Sorry, I'm sorry to interrupt. Go ahead.
So you know, balloon expandable device has a relative the small profile, so it's easy. 还空吗？还空吗？
可以了吗？可以了。
OK，
好，不让吗？
Does this valve come with an expandable sheath?
Made device. There's
这是 homemade production.
there's some different with that of the saving suite, including the sheet
Getting progress. Getting
and also
progress.
the valve itself. You can see.
你把心脏抹到当中来。
好，
Good.
来，
Homegrown sheath. Okay.
这是多少？
Professor
这
Wang
是
and Liu, is this domestic balloon spindle valve from China is different from anything different from the sapien valve?
Although, okay, I invite Dr. Liu to answer the question.
yeah. So the sheath is different, and then the valve is also already loaded.
So it's mounted on the balloon.
Yeah. You can see right there.
再移一下，不太容易出去。就是
跳在这里吗？跳在这里。
啊。
Does it come in? Is it more like the MyVal? Does it come in more sizes, or is it more like the Sapien in the
有什
sizing?
么不一样？回答一
Yeah,
下。
the size is the same. 20, 23, 26. 我等一下啊。
Same as the
等一下吧
Sapien. Okay.
Yeah. So however, it's already loaded.
Yeah.
Oh, it's a different from the sapien. The
Yeah,
sapien is
Some
when we
stage. 我等一下啊。
already loaded
这个
before we before we put the device in. Actually, it's already loaded.
Yeah. 我是你轻轻往里边。
You can see that?
我是慢点。
Yeah, it makes it
Light.
simpler,
我是拉一点。
even simpler.
我是等一下，
你要往这后面拉一点。
这是他拉的。 王老师他在拉，明白了，慢点，王老师
这个
慢点，
稀释小众。
慢点，王老师慢点，好，他达到 Copeland view 来，王老师稍微慢点
Now we are going to the projection of a coplanar view，
，yes，OK，
不要污染掉，你们这
没有，
后面
王老师没有，来
It was 26.
26.
26，王老师，哎，好，等一下，慢点，王老师，好，OK，good，OK，OK，来，王老师，你这个出来哈，把这个出来，
你把
我出来 ，OK，好，然后诸位重新弄一下，好，我知道。
Is this deflectable or is it
往
just,
上还是往下
just
收？
like a balloon? The catheter doesn't look like it's deflectable.
啊，就是往下往上收。
对，王老师，
那我们要
们
push
下
forward，
去多一点，
下去一点。
好，OK。
那有实力吗
力量稍微松掉一点点，力量稍微松掉一点，
什么？
力量稍微松掉一点点，否则等会还会往里边走。我觉得可以先180，我们先试一下，拿个照相机看一下。
啊，
很高啊，是吧？可能再下去一点点。好，OK，好，好，
我们做照影看到吧？先
对
起吧。
实时联动，我们180
你要
起搏一下，
起搏吗
我们再
起搏
起搏以后，我们再试一下，等会再
起搏
进起搏。
嗯
谁在管起搏？对，我们起搏先试一下，等会再停掉啊。什么都不做，哎，王老师，好，听王院士指挥啊。
哦，你起搏吧。Start pacing, please。
好，挺好，挺起搏。
停起搏。Stop pacing。
可以。
Blood pressure comes back.
Yes。
Now we just make a judgment about the height
我
of
觉
the
得
device。
可以往回拉一点
不
点
要。拉了，
好，可以，好，
差不多太往上说了。
可以，
180够不够？
可以，那么就200也可以，好，那就您指挥啊。
怎么样 ？OK。
好，
所以谁来把这个啊
王厉害吧？哎，好。
？OK，stop pacing, please.
200。
200 beats per minute. Stop pacing. 起搏。
好 ，DSA。王老师，我起来了啊。
啊，起。
好，拔掉。王老师，稍微顶掉一点，顶一点。
1、2、3、4、5。
好，起步转下来，
转下来，转下来。
转到，好，转下来80。王老师，稍微等一下，王老师，稍微等一下，王老师等一下。
而且你转。
好，王老师等一下，再转下来。
Really rotated.
好 ，OK。
curves complex become wider.
打平，
I don't know. Come back.
打平，
Good.
把半膜打平。来，哎，来，
There you go.
下来一点，下来，厉害，来，下来一点。
Can you show us the deployment again? It seemed like it rotated quite a bit. as it
Okay,
was
Okay.
being
Okay.
inflated.
Could you go back?
厉害，放下。
Blue low.
Just
Go
interesting to me.
playing back. Playing back. 再上来就不行了。
Maybe not.
对
Maybe not.
挺好的。
前面
Maybe I misremembered. Look, it ended up more horizontal than I thought.
you
it
can
would.
see
little bit, but not
a little bit
much, not much.
shortening.
Yeah.
The distal edge has a large shortening, right? Has a
Yes.
big shortening.
Yeah.
Compared
Yeah.
with the sapien 3. Compared with the sapien 3.
Cross wave and the
So
hemodynamics.
now
shortening.
you can see that hemodynamics was is a quite stable. Blood pressure is 190 over 54. Heart rate is very good with a narrow curve complex.
Yep. Looks very good.
So
do
we
you
don't
think you-
know whether the patient has a. So we can check echo now. We can check
好，来，超声。
chest.
好，OK。哎，我们再把那个
So
注
usually we didn't do the TE for TAVR patients.
Right.
So this patient also we
Right,
just do
yeah.
the
我们顺便把那个血流动水测一下
transthoracic echo. 你把这个探头。
好，王老师，我们把朱伟先放进去。
So now we are going to put the pigtail in
Yes.
the left ventricle. Then we do the
Check the gradient.
now we check the pressure gradient first. Then we do the echo.
Sounds good.
So now the picture in already. OK.
好，
这是形式中。可以啊。
OK，好，
clear.
Don't see any AR there.
Now we are checking the
gradient，
pressure grading.
呀，这里应该没有什么反流。
So can you see the echo?
We see the
Can you see
echo.
the
yes.
echo? It's a five chamber view. From the
Yep.
5-chamber view, we didn't see any regurgitation. So now we are checking the pressure grading.
Velocity is about less than 2, less than 2.
The velocity, the peak velocity is less than 2, right?
Yes, less than 2.
Less than 2. The pressure,
Seven.
the pressure grading.
Yeah,
Yeah,
minimum is a 7.
Okay.
From echo, 大概 about 7.
Now we
Yeah.
check 0.
Yes, sure. Yes. Okay, you can see. 再调一下。来，我们把血流动力学放到桌面，换一个。
It looks
Yeah,
very,
Gradient,
very
yeah, very
equal there.
good.
No gradient on
Yes.
HEMOS.
Yes.
No AR.
Nothing by echo.
我想可以了。好。So we will do the final shot. 来，再让我
Do
们
a
大好。
aortogram now.
Picture 出来吧 withdraw the picture. So
对
you can see that almost the pressure grading almost disappeared.
Yep.
都
Looks
收
good.
联动。
And now
great.
we pull back the pigtail, then we do a final shot in
That's
the
right.
order. Okay. 来吧 So we like to get the Y in, then take out.
好
Okay.
Yes.
Now we are going to final angiogram to see what is going on.
Yeah, please.
准备好了吗？
可以了。
15吗？
15联动。
Okay.
Perfect result.
Great.
It looks,
Good.
can't be
Even
better.
shorter than CP3. I think the domestic
Yeah.
production device is shorter than CP3. Very short.
It looks very short. I mean, it looks like the
Alright.
old
So we
XT, you know, that
you're right. You're right. Because of very short, so we don't concern about too much about the blockage of the orifice of coronary artery.
Yeah.
So
yeah,
any
that's
more
remarkably
comments?
short.
Welcome your comments and welcome your suggestions.
Any of our panelists have comments or?
So I have a questions. The system is very
你要塞一个什
interesting.
么东西？
So my question is, if necessary, you can take out the valve before implantation. You mean the supplementary we cannot take out the valve?
So can you remove
Remove,
it
yeah,
through the sheath? I doubt it, but can you take this valve out if you
The sheath. Yeah.
before you deploy it?
Yes. Yeah, we
Yes.
can take it out. Yes.
We can
You
take
can
it
get
out.
it,
Yes.
you can
No
get it
problem.
back into the
Yeah.
sheath. Well, that's
How
Yes.
big is the sheath?
Yeah, yeah.
What French sheath are you using now?
So this is
18.
the 多少？18吗？
18 French.
18
18.
non-expandable.
French. 16, 16.
Yes.
16.
But is it an expandable sheath or is it a fixed sheath? It's a
Expandable.
Expandable.
Expandable
16
sheath.
French expandable. Okay.
We don't need the pullback.
Yes,
Just
yes.
put it in.
Yeah.
take
For
it
that.
out.
Well, I think that's a beautiful demonstration, and really thank you so much for educating us about the Hangzhou solution, which I think is a very novel approach, and showing us a new valve, which looks a little like an old valve that we know, but really worked very, very well in this patient. So I think it was very, very educational. SJ, you want to
Okay,
Okay.
thank
sign
you.
off?
All right.
Yeah, no, I think
It's great. Very interesting things. Dr. Wang, you just decide the typical size depending on a pre-balloon size, right? 23,
the smaller balloon.
and then smaller balloon, and then choose a 26.
Yeah.
Okay, great.
Well, I think this was a
Very
very,
simple.
we saw two different,
right.
Yes.
Great.
two different bicuspid cases, both used balloon expandable valves, slightly different sizing algorithms for both, and both got perfect results. So hard to argue with success. Thank you so much, Dr.
Great
Wang, for
case.
joining us today.
Thank you all.
Thank you.
Congratulations on the so
Okay.
successful still
So
valve
now
meeting.
we are going to
Thank you.
learn not